Hello. So today we will be talking about congenital TB, congenital tuberculosis. We say congenital tuberculosis if it is acquired, infection is acquired antepartum, or it is intrapartum. Now, usually the antepartum accusation of the infection is either due to hematogenous spread, which primarily involve liver, lungs, or due to aspiration of infected amniotic fluid. In that case, lungs are involved. And intrapartum accusation of the infection is most of the time due to aspiration of the infected amniotic fluid or infected genital secretions. One thing very important is that younger the age of TB acquired, higher the risk of disseminated TB or TBM. So congenital tuberculosis always put a newborn at risk of developing the disseminated TB or TBM. As I said earlier, the three mechanisms of transmission is that transplacental aspiration of the infected amniotic fluid and ingestion, which involve the guts. Specifically, clinically presentation, usually newborn present will be like the sepsis-like symptom, poor feeding, fever, irritability, and in the longer run, the failure to thrive. Hepatosplenomegaly, lymphadenopathy, otitis media, and cutaneous manifestations or other possible manifestation of congenital TB. When I was looking for the sign, as per literature, respiratory symptoms are the most important. Respiratory symptoms are the most common, followed by hepatosplenomegaly and splenomegaly in 65% of the patients. Fewer lymphadenopathy and poor feeding was noted in the same sequence with decreasing incidence. So whenever you get a newborn with respiratory distress, hepatosplenomegaly and fever, this slide should prompt you to think about tuberculosis, congenital tuberculosis. Now, diagnostic criteria. Actually, there are three existing clinical criteria, but the countable criteria is one of the most important criteria, and it says that if you have approved tuberculous lesion or disease in a newborn with one of the four, like the lesion in the first week of life, such as the lesion appeared in the first week of life, or there is a primary hepatic complex or caseatic granuloma of the liver, or the third is a TB of the placenta or maternal genital tract, and in the fourth one is exclusion of the postnatal transmission by testing the people around the baby. So if you have the first one and one of the four others, so this will qualify for a congenital tuberculosis. Now, the next thing is evaluation. What we do when we suspect a probable tuberculosis infection, congenital infection. So, X-ray, chest X-ray, epi and lateral view is of certain diagnostic value. TST, or tuberculin skin test or Marto test, is although unreliable in the newborn period, but if it is positive, it is a supportive test, and sometime the IGRA should be or considered in vehicle testing. TST is unreliable because of the low reactivity, and so most of the time it will be negative. Mycobacterial confirmation is done with the study of the gastric aspirates, blood culture, endotracheal aspirate, ear discharge, or a pleural feed or skin lesion swab. So one thing should be important, that if you detect mycotuberculosis DNA in bronchoalveolar lavage sample by PCR, it's diagnostic of the TB in the newborn period. Okay, now let's say we have a mother who is TST positive, but her chest X-ray is normal. So in this case, the newborn is not separated, and we treat the mother for the latent TB, and we also do contact tracing so that to find out who is the actual culprit in this case. Similarly, if the mother is symptomatic and or having abnormal X-ray, so we evaluate both the newborn for a possible congenital infection, and mother evaluation is also sorted in the same at the same time. One thing should remember: if the mother is diagnosed during pregnancy, so she should be started on anti-tuberculosis, and no abortion is indicated. Termination of pregnancy is not indicated. Newborn evaluation will include all the testing, and if say the newborn is not infected, or the newborn does not fulfill the clinical criteria, so we will put him or her on INH prophylaxis for 6 to 9 months, and up to the completion of prophylaxis, chemoprophylaxis with INH, we will do a TST, and if it is negative, we can vaccinate the baby with a BCG vaccine. Similarly, in the same time, we evaluate mother, and if we are interested in TB, and if she is TB positive, so we start her on anti-tuberculosis therapy. Now, as we were evaluating both mother and newborn, so we have to keep them separated, and as this separation, as the process complete and the baby is on INH, we do not recommend to separate the mother and newborn, unless there is one instance in which the baby should be separated, and that is if the mother has a drug-resistant TB. Then it's the only indication that we have to separate the baby from the mother. Now, here, if you noted, the newborn was evaluated, and he turned out to be not infected. So the other possibility is that he will be congenital. He is infected. So let's say she is has congenital TB. In this case, we give these 3 drugs per oral, and 1 injectable aminoglycoside like amikacin is given for 2 months, and then we continue with INH on rifampicin for 4 months to complete a total 6-month duration. The mother, the newborn is exclusively breastfed, and we also add pyridoxine to the regime. Okay, let's say if he or she is having a sinus infection, we also add prednisolone 2 mg per kg, not exceeding to 60 mg per day to accumulated dose. It should be given 4 to 6 weeks, and therapy should be continued until all signs of meningitis disappear in culture or negative on 2 LP at least 1 week apart. Similarly, prednisolone can also be given in disseminated TB, other types of severe tuberculosis infection. One word on the breastfeeding, that in low resource income, the breastfeeding is not recommended to be stopped. It should continue because the hazards of formula feeding and alternative to breast milk feeding are far more than actually the breastfeeding, the chance to transmit the disease to a newborn. American Academy of Pediatrics, however, recommend if the mother is negative, or if she has 2 or more than 2 weeks of adequate therapy, so breastfeeding should be continued. Otherwise, express spilled milk in a smear positive mother or a formula feed is recommended. Thank you so much.